All right, welcome back, everyone, to all the pharmacology students, veterinary technicians, and future clinicians tuning in today. Okay, let's dive straight into this. We are tackling a massive, incredibly important topic in this explainer: ectoparasiticides. These are essentially the chemical weapons we use to protect our patients from external parasites. Now, this is a super high yield topic for your board exams, but honestly, way more importantly, this is the kind of practical knowledge that is absolutely going to save lives in the clinic. So here is our game plan. We're going to start with the setup, our targets and delivery methods. Then we head straight into the neurological battlefield. After that, we'll look at disruptors and synergists, and we'll wrap the whole thing up with the exam goldmine, where we'll hit those crucial life or death clinical takeaways. Okay, Chapter 1, the setup. Because before we can really dig into the heavy pharmacology, we need to clearly define the enemy we're actually fighting and how exactly we get our chemical weapons to the front lines. The material we're covering in this explainer comes straight from an incredibly solid board prep and clinical reference guide. You should absolutely treat the specific breakdowns and protocols we pull from this as your holy grail. If we're talking about it today, you need to know it, both for your exams and for when you're out there on your clinical rotations. First things first, know your targets. Ectoparasites generally fall into two taxonomic camps. We've got class Insecta, so your houseflies, lice, and fleas, and biologically, these guys are characterized by having 6 legs. On the flip side, we have class Arachnida, your ticks and mites, which are 8-legged, and understanding this basic biological difference is absolutely crucial, because some of our drugs target specific anatomical features that are completely unique to just one of these classes. Which kind of begs the question, what exactly makes for the perfect weapon against these pests? Well, there are 5 non-negotiable traits we're looking for in an ideal ectoparasiticide. We want something broad spectrum, right? Something that destroys both insects and arachnids. It needs to wipe out not just the adults, but the eggs and larvae too. Crucially, and this is a big one, it must be completely non-toxic to our host animal. We also need it to be highly stable, giving us long residual activity on the animal's hair or skin, while still kicking in with a rapid onset of action. It's a pretty tall order for pharmaceutical engineers, to say the least. And once we actually have that ideal drug, how do we apply it? Well, delivery methods are always tailored to the patient. For massive herds of cattle, you might be looking at dips that require complete immersion for total body coverage, or porons applied right down the dorsal midline. Now, for our companion animals at home, spot-ons are incredibly common. They're highly concentrated, super convenient, and applied to a small area on the back of the neck. We also lean heavily on slow-release technologies, things like collars made of thermoplastic resin or ear tags for livestock, which provide a volatile, slow-release action over several months. Okay, so we know who we're fighting and how we deploy our drugs. Now let's shift gears and look under the microscope. We are entering the real core science of this explainer, the neurological battlefield. This is our central metaphor today. The vast majority of these drugs work by literally turning the parasite's own central nervous system against it. Think of this as a synthesis arc that outlines our 5 major receptor targets. We can go after sodium channels or target acetylcholinesterase. We can also attack GABA and glutamate-gated chloride channels, nicotinic receptors, or even octopamine receptors. So let's break down these specific drug classes one by one so you really get a feel for how they operate. First up, we have pyrethrins and their synthetic cousins, the pyrethroids. These are sodium channel modulators. Their mechanism of action is just fascinating. They essentially jam the parasite's transmission lines. By delaying the closure of sodium channels in the axonal membrane, they allow this massive, uncontrolled inward flow of sodium. This triggers repetitive neuronal discharges, total membrane depolarization, and ultimately it kills the parasite. And while they have remarkably low toxicity for a lot of mammals, I literally need you to pause and lock this into your brain right now. Permethrin is highly, highly toxic to cats. Never, ever use it on felines. This is a fatal clinical error that happens way too often when well-meaning owners accidentally apply dog flea medication to their cats. It triggers severe tremors, violent seizures, and it can absolutely be lethal. Please, do not forget this. Moving on to our second target on the battlefield, acetylcholinesterase, or ACE. Drugs in this specific class inhibit ACE, which basically means acetylcholine cannot be broken down in the synapse. This causes a massive, overwhelming accumulation of acetylcholine and dangerous synaptic overstimulation. In patients that accidentally get overdosed, this manifests as classic sludge toxicity. That's salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis, usually accompanied by severe muscle tremors. Now, the two main drug classes that do this are organophosphates, or OPs, and carbamates. There is a critical distinction here for your exams, and it comes down to how they bind. Organophosphates bind irreversibly. They are highly lipid-soluble, they penetrate deeply, and they are much more acutely toxic. Carbamates, on the other hand, bind reversibly. They have a shorter duration of action, and broadly speaking, they're less potent and a bit less toxic than the OPs. Now, what's really interesting is the wildly unique profile of Amitraz, which is a formamidine. Instead of sodium channels or AHE, Amitraz goes after octopamine receptors, and it is incredibly effective against really tough parasites like demodex mites and ticks. But it comes with some absolutely strict clinical boundaries. You must explicitly avoid using Amitraz in horses. It completely halts their gastrointestinal motility, causing severe, often fatal impaction colic. Oh, and it is also totally contraindicated in cats and chihuahuas. Thankfully, modern pharmacology has given us some incredible tools with highly targeted specificity. Take neonicotinoids, for example, like imidacloprid. They target nicotinic cholinergic receptors. But here's the genius part. Mammalian receptors are vastly less sensitive to it than the insect receptors, so the safety margin for our patients is just excellent. Then you have phenylpyrazoles, like Fipronil, which block GABA and glutamate-gated chloride channels. And get this, those glutamate-gated channels don't even exist in mammals. This is exactly why Fipronil can safely accumulate in a dog's hair follicles, giving long residual protection against fleas and ticks without harming the dog. Our last stop on the battlefield covers the systemic drugs. Macrocyclic lactones, like Ivermectin, travel right in the host's bloodstream. When a parasite latches on and takes a blood meal, it ingests the drug, which rapidly causes paralysis. And finally, we have the botanical extract rotenone. It works by halting ATP production in the mitochondria, but you really have to beware here. It is highly toxic to swine. It must never be used in pigs, and to make matters worse, there is no specific antidote if you do. So we've gone over the heavy neurological weapons that kill adult parasites. But what about the rest of the life cycle? Let's transition to Chapter 3, Disruptors and Synergists. These are the specialized tools that sabotage parasite development entirely or significantly amplify the power of our other drugs. Let's start with insect growth regulators, or IGRs. The absolutely crucial concept to grasp here is that IGRs do not kill adult insects. Not at all. Instead, they act as developmental disruptors. A drug like lufinuron is a chitin synthesis inhibitor. It literally blocks the development of the insect's chitin exoskeleton. So when an adult flea lays its eggs, those eggs simply fail to hatch. Other IGRs, like methoprene, actually mimic juvenile hormones, trapping the insect in the larval stage forever. It's a remarkably safe and clever way to prevent environmental reinfestation. Then we have the fascinating concept of pharmacological synergism. Honestly, this is a classic exam question just waiting to happen. Pipernyl butoxide, or PBO, is a synergist. On its own, it has absolutely zero insecticidal activity, none. But when you mix it with a drug like pyrethrin, PBO steps in and inhibits the insect's microscopical enzymes. It basically prevents the insect from breaking down the pyrethrin, which massively increases both the potency and the duration of the main drug. It is the ultimate pharmacological wingman. All right, we've covered a ton of ground. From the biological targets to synaptic warfare, now it's time for the real climax of this masterclass. Get your notes ready, grab a screenshot if you have to, because we are entering Chapter 4, the exam goldmine. Our first cheat sheet deals with the absolute clinical boundaries. Let me be clear. These aren't just multiple choice test answers for you to memorize. These are fatal species contraindications. Knowing these inside and out is exactly how you protect your medical license and, more importantly, how you protect your patients from catastrophic harm. Let's methodically run through these. Permethrin, never in cats due to extreme neurological toxicity. Amitraz, never in horses because it causes fatal impaction colic. Amitraz is also totally banned for chihuahuas and cats due to idiosyncratic and generalized high toxicity. Rotenone, highly toxic to swine. And finally, a huge drug-drug interaction warning. Never use organophosphates simultaneously with other ACE inhibitors because you will create a compounding, highly lethal toxicity scenario. But hey, what happens when an accident does occur? A stressed client rushes in with a dog they accidentally overdosed, or a cat that got into the wrong medication entirely. This brings us to the final critical piece of the puzzle, knowing exactly how to reverse the damage. These are your lifelines. For OPs and carbamates presenting with those classic sludge signs, you immediately reach for atropine to block the muscarinic effects. If you know it's specifically an organophosphate, you also add 2-PAM to try and break that irreversible bond we talked about earlier. For Amitraz intoxication, which causes severe sedation and bradycardia, you need alpha-2 antagonists, so things like yohimbine or atipamezole. For pyrethrin toxicity, there actually isn't a specific chemical antidote. Instead, you're controlling the seizures with diazepam, treating the tremors with methocarbamol, and bathing the animal immediately with dish soap to halt any further skin absorption.
Let's put all this to the test right now with a real-world clinical scenario. If a frantic owner runs into your clinic holding a cat that is presenting with severe muscle tremors right after they applied a topical flea treatment they just bought at the grocery store, what drug was likely used? And much more importantly, what exact steps are you going to take right in that moment to save that animal's life? Think back to the tables we just covered, trust in your pharmacology training, and go absolutely conquer those board exams. Thank you so much for joining me on this explainer, and I will catch you on the next one.